بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين. Today we will talk about localization of CNS lesion. We will hope for ثورة ديسمبر المجيدة، أعظم ثورة مرت على تاريخ السودان. نترحم على شهداء ثورة ديسمبر المجيدة وعاجل الشفاء للجرحى. Today we will talk about anatomy of neuronal pathway. What are the type of localization? How to localize sites of lesion. Finally, we have question quiz for check understanding. You must be aphasic or you must be aphasia because you let me speak less. Yes, for choke. A division of neuraxis. Firstly, cortical brain. Secondly, subcortical areas, brain stem, then cerebellum, then spinal cord and root. Finally, peripheral nerve, and finally muscles. This is an image illustrating anatomy of neuronal system or nervous system. In the upper part of the image, cortex, frontal lobe, temporal lobe, parietal lobe, then the brain stem in form of midbrain, pons and medulla, then the spinal cord until the muscle. There is rule to localize CNS lesion. Symptom and sign give you site. 3S. Symptom and sign give you site. So we finish the anatomy of neuronal pathway. Then we will speak about types of localization. Okay, type of localization. Simply we can say, is it left or right? Is a type of localization. Or is it intra or extracranial lesion? Is a type of localization. And so on. Central nervous system, peripheral nervous system, upper motor neuron type or lower motor neuron type. Is it pyramidal or extrapyramidal? Is it bulbar, pseudobulbar? Is it muscular or neurological? Localization. Regarding a motor system, the motor system is in the central nervous system consists of brain, spinal cord, beginning in the motor cortex, extending down to brain stem and spinal cord, to end at the lower border of L1 at the end of spinal cord. So we will speak about motor tract, pyramidal tract, which starts in the frontal loop, mainly motor area 1. Then corona, we will through the corona radiata or corona radiate enter the internal capsule, then brain stem, then become two pathways: corticobulbar, which you go for cranial nerve nucleus, and corticospinal, which you go for anterior horn cell. Okay, this is anatomy of motor cortex or motor pathway, pyramidal tract, starting from the pre-central gyrus in the frontal lobe, cerebellar peduncle, midbrain, medulla oblongata. At the end of medulla oblongata, decussate to opposite side. Sensory system comprised of nerves and tracts which carry stimuli arising from the peripheral, including skin, joint, muscle, and viscera. View the peripheral nerve system to the posterior root to enter the spinal cord. There is two pathways: spinothalamic tract and dorsal columnar tract. Spinocerebellar tract which carry pain and temperature, dorsal columnar tract which is carry position and vibration. Okay. This is another sensory pathway, posterior column. This is a image for neuron, which is site for memories. The brain, just for joke. Don't get me, don't get on me. We finish type of localization. How to localize site of the lesion. We will give you the hint that guide you for localizing a lesion, uh, just like guiding point. Firstly, is it cortical brain lesion or not cortical? After you say cortical, dominant or non-dominant? Uh, Dominant hemisphere, right-handed people almost 97% have left dominant hemisphere, and left-handed people 75% still have a left dominant hemisphere. On the other hand, 25% of left-handed people can have bilateral dominant hemisphere. If dominant hemisphere affected, will manifested by loss of cortical sensation like stereognosis and upper motor or lower motor neuron type. Upper motor neuron type, any lesion above anterior horn cell of spinal cord and cranial nucleus in the brain stem. Lower motor neuron, anything below that is the muscle. Main differential between the upper and lower motor neuron lesion are wasting and fasciculation are unique. Wasting and fasciculation are unique for lower motor neuron type, especially fasciculation. Wasting can occur even in the upper motor neuron type due to disuse atrophy, but fasciculation is pure lower motor neuron. This is a comparison between the upper and lower motor neuron lesion. Unique feature of dominant hemisphere. Dominant frontal lobe absolutely will be damage of Broca's area, which is responsible for expressing of speaking, will lead to expressive aphasia. Dominant temporal lobe will lead to vernix aphasia, which is receptive aphasia. Parietal lobe will lead to hemineglect, and a lot of lesion will be associated with such lesion. But there is a lesion which will guide you toward the dominant hemisphere or dominant lobe affected. Cortical lobe is area of vision. So dominant cortical lobe lesion will lead to cortical blindness and visual hallucination and micropathia. Subcortical, what do we mean by subcortical? Subcortical mean there is white matter. Subcortical mainly it is white matter, axon, radiating fiber and tract. But also there is gray matter in form of cell body of neuron in the cortical area such as basal ganglia and summary for each lesion. Move. This is an illustration of pseudobulbar and bulbar palsy. Nuclei in the cortex, nuclei in the brain stem and the target organ. From the cortex until the brain stem, this is a pseudobulbar. Any lesion in this tract is pseudobulbar, supranuclear pathway, which is upper motor neuron type. Below this, lower motor neuron type, which is bulbar palsy. Okay, this is a comparison between upper and lower motor neuron type. How seizure and aura can help localize of the lesion. Yes, some seizures have a specific feature, specific aura, which guide you for localizing site of abnormal electricities or generation of seizure, such as frontal lobe seizure will be have a very bizarre aura. Even you can kill the patient, kill the another person when the aura come for you. Visual aura is usually in the occipital lobe region. Thank you for your attention. The answer will be verbal through the discussion.